All right, next kind of big category of questions is, do the vaccines really work? So we kind of see people's concerns on a spectrum here. We've got people that, maybe a few that think, well, I'm vaccinated, I'm bulletproof, I can do anything. We kind of thought that at the beginning. It was really looking strong and good. And I think a lot of us were looking at the prospect of a really enjoyable summer and, went out and kind of acted that way, I think appropriately, after vaccination. But now you've got reports more and more of the vaccine efficacy faltering. So you've got people who are worried if it's going to protect them. You've got people who are skeptical or a bit cynical, maybe that, okay, look, it looks like the vaccine's not working anymore. Why bother? So what's the kind of actual data on this? Well, we do have reasons to think why the vaccine efficacy might decline. Our immune system, after we're exposed to an infection or after we're exposed to a vaccine, mounts a big response normally and then does start to decline normally as time goes on. So time from the vaccine is likely to make antibody levels fall. We know that the older we are, the less well we respond to immune challenges, like viruses or like vaccines. So the aged, who were some of the first people to get vaccinated. So again, more time out, older, two things kind of conspiring to maybe make the effectiveness a little worse. And the Delta variant itself might be changed enough that the vaccine, which is made against the original strain, might not work as well. So there are some reasons to expect this. And what are we seeing? We are seeing that for infection or symptoms, the efficacy in the real world setting, the clinical trial showed almost 95% efficacy or protection, really looked great. Out in the real world settings, that was around, 87, 89% up to around 96, 97%. So pre-Delta, real world efficacy was also looked very, very good against infection or symptoms. With the Delta wave, this is a few of the studies that are out there. There's a number of them. It's fallen anywhere from a low in Israel, reporting as low as 39%, to places like Canada saying 64% protection with the Delta flare. I think we're probably going to settle in somewhere in the 65 to 75% range would be my guess on protection against any infection or symptoms. But we don't make vaccines to prevent colds and mild flu-like illnesses. We make vaccines to prevent hospitalization and death. That's the real outcomes of concern. So how are they faring against hospitalization, severe disease, or death? A little bit of decline, but still holding up pretty good. So here again, this is, I think, Israel on the low end, declined down to about 75% protection. Israel's, rolled their vaccine program out the earliest of all of us, and vaccinated the elderly the earliest. So we're seeing the effect of age and time maybe causing a little bit of decline even against severe disease, but still pretty darn good. Even 75% we would say is a pretty good vaccine. Most of them holding in the 80 to 90+% range for protection against severe disease or hospitalization or death. It's higher even for death. We need to see the data out a little bit longer there, but that's still in the mid 90s or higher for death. And this is data from 13 states now reported in the US. This is the age-adjusted hospitalization rates. So per 100,000 in the unvaccinated versus the vaccinated. And this is as we are moving into Delta here in July in most of the country. And you can see the unvaccinated have vastly more hospitalizations. So here we're just focusing on severe disease than the vaccinated in green. Although the vaccinated are having a little bit of a creep up also in severe disease. But a big difference between these two groups, not only in the overall rates, but in how they look. So in the unvaccinated, the median age is around 59 years compared to the median age in the vaccinated group, 73 years. So the people who are breaking through and landing in the hospital are older. They're also sicker. 71% of them have 3 or more underlying bad health conditions compared to only 56% in the unvaccinated group. Also more likely to be frail nursing home residents, 15% of the hospitalized people breaking through are nursing home residents in the vaccinated group, compared to only 5% nursing home residents in the unvaccinated. So unvaccinated is shifting to being slightly healthier, younger people compared to those that are breaking through with severe disease in the vaccinated. And the numbers are much less. If we take the younger age group here, 18 to 49, plucked out of this difference, it's a 23-fold difference in hospitalization rates. Huge amount of protection against hospitalization from the vaccine. We can see that age is a major factor here. This is Israel's data, and this is again severe disease per 100,000 people in the unvaccinated group, per 100,000 in the partially vaccinated, and per 100,000 in the fully vaccinated. And you can see the red. If you're unvaccinated, you have a much higher risk of developing severe disease than the people in the gold or the green that have gotten one or full vaccination. But you can see severe disease creeping up in the very elderly. So starts kind of even a hair of it there above the age of 50, a little more above the age of 60, really visible in the 70, 80, and 90-year-olds. So not too unexpected, immune response in the elderly is never as good. And so the vaccine isn't protecting them quite as well as we'd like, but much better than the unvaccinated. If you're unvaccinated and you're in your 60s, 70s, 80s, 90s, you're just really taking your chances and playing with fire. So kind of to summarize this, vaccine efficacy in the presence of the Delta variant went from about 95% in the clinical trials, maybe around closer to 90% in real world efficacy, to after Delta, 40 to 85%. Against severe infection, still holding pretty good at 75 to 95%, which is what we want vaccines to do, protect against severe disease. All right, what about booster shots? The jury is still out on this. We do have a recommendation for those who are very immunosuppressed, like lymphomas, leukemias, on chemotherapy for other cancers, organ transplant recipients, people on high-dose steroids, people on other drugs that severely suppress their immune system. All of these people are eligible for a booster now. And it's actually not even really appropriately called a booster in that group, because those folks never got a good immune response from the beginning. I mean, a good chunk of them, up to half, maybe didn't get a very good immune response. So we're not boosting them. They actually need an extra dose. They probably need a 3-dose series to get any decent immune response from the beginning. But I think, most of the rest of us we have good evidence that we make a good initial immune response, but it just may fade over time, especially frail elderly, like in long-term care, people maybe over the age of 75 or 65, time away from your last vaccine. These, I think, are all eligible groups to be considered for a booster. The CDC's Advisory Committee on Immunization Practice will be, I think, reviewing this here sometime in the next few weeks in September. And I suspect they'll issue guidance on this. My suspicion is they'll recommend it for long-term care, and they'll recommend it for some group over a certain age, I suspect. And they may put a time limit on that, like, after, if you're maybe 6 months or 8 months after your after your last dose of vaccine. I suspect they'll also consider healthcare workers, because we can't really afford any shortages in the healthcare workforce due to illness. And we want to make sure healthcare workers aren't bringing it in to frail elderly or people with underlying significant illness. So I think these will be the categories considered, but we're waiting to see what the CDC says. We should have that very soon in September here. What about the person who says, I've already had COVID? Maybe I don't need the vaccine. I think that's actually a very fair question. This kind of warrants a harder look. And there's a bunch of conflicting data out here right now on this. A lot of people talking about a non-peer-reviewed study out of Israel, which I'll touch on in a second. So let's do a deeper dive on this. So the study that people have started to refer to out of Israel that hasn't been peer-reviewed yet, hasn't been put out in a formal publication. They put it out as kind of like one of these early release preprints, they're called. So sometimes these don't vet out to be, a valid or good study, or they undergo changes and have to revise their data when it gets actually published in a medical journal. So just take it with a slight grain of salt. It's a good group of people that worked on this. I don't doubt their results, but I think we got to wait for their final publication and after it has appropriate peer review. But what did they do? They matched a little over 16,000 people in two groups: those who had had a prior 2 doses of the vaccine, or people who had a prior infection. And in this comparison, they tried to match them up roughly in time for when they got their infection and when they got their vaccine. So that's a good kind of grouping. And what did they find? They found out of those 16,000, 238 people got a breakthrough infection. Most of those, so about 1.5%, so not a lot, got a breakthrough infection. Most of those were mild. 8 of those landed in the hospital and did well. Nobody died. Compared to those who had a prior infection, only 19 or 0.12% got a subsequent infection. So that was a 13-fold higher risk of an infection in the people who'd gotten a prior vaccine compared to infection. Now, that has been, touted as looks like prior infection may be better than vaccination. That may very well be true. And in fact, in most circumstances, prior infection tends to be better at giving you an immune response than a vaccine. Now, that is not to suggest at all that we should go out and get infected to protect ourselves, because what they didn't show you here is, and what they excluded from their study, is how many people died, or how many people with their first infection, their prior infection, got really, really sick or have long COVID or any of the other problems that come with that. You got to survive all that stuff to look at, see what kind of subsequent protection you have. That's not a good path towards protection. And if the prior 2 doses turns most of these into mild colds or mild flu-like illness, that's okay. I mean, if it's protecting against hospitalization and death, that's okay. Now, this group did have had 8 hospitalizations, where this one only had 1. Those are too small a numbers to have a very good statistical analysis yet. Hopefully they'll get bigger numbers and bigger data to see if that bears out. But it does look like prior infection was pretty good at protecting against both infection and maybe severe disease. 8 out of 16,000 people in this group that were hospitalized is a very low number. So it was very protective against hospitalization and no deaths. Here's the kicker from this study that didn't get mentioned most of the time. They also compared it to another group of about 12,000 people who had a prior infection and got at least 1 dose of the vaccine. That group was the best of all. They had an additional 53% protection or 53% lower likelihood of reinfection compared to the prior infection group alone. They were the best. Hardly any infections broke through in those who had a prior infection and 1 dose of the vaccine. Same thing was found in a study in Kentucky in the United States. They found that people with prior infection did pretty well, but people with prior infection and at least 1 dose of the vaccine did the very best. Same thing in Kentucky, found almost the exact same results, a 57% reduction. Let me show you some data that kind of goes against what was seen in Israel there. So that's a good study because it's clinical data. This is data more from a test tube. So I would say the Israel studies got something over this, but I find this data interesting as well. This was from the Journal of the American Medical Association. And these are people who had no prior infection at their baseline after 1 dose of the vaccine and 2 doses of the vaccine, compared to a similar group of people who had a prior infection and then got 1 dose of the vaccine and got 2 doses of the vaccine. And then they looked at how much antibodies they made. So let's just take a look at this. So first of all, from people who had no prior infection to an infection, they made antibodies. If you got infection, you made antibodies. And this is a logarithmic scale. So each line that goes up is a 10-fold difference. So this is like, what's that? It's almost like 10, like almost 100. That's probably close to that's a little over 1,000-fold difference. No really minimally to no antibodies to, very high levels of antibodies. But the other thing to point out here is that 14% of the people who had an infection didn't make any antibodies. They're the same as basically those who had nothing. That ought to give us a little pause that 14% of us, maybe don't make any antibodies to our infection. And we've seen from other research that that's especially true if you had very mild disease. Like if you had no symptoms or very mild symptoms, most of them either make little to no antibodies or they fade away very, very quickly. So if you think like, well, I had outpatient COVID and it was really mild or asymptomatic, I'm protected. You're probably more likely to be amongst this group that didn't do much. Here's the other thing is that if you looked at the vaccinated subjects compared to those with a prior infection, the people who had no prior infection and got 2 doses of the vaccine had about 10-fold higher antibodies than those with prior infection. So got the Israel data showing some clinical numbers. We've got this data showing higher antibodies from the vaccine. But this kind of confirms what that Israel study showed too, that those with prior infection and full vaccination or even 1 dose of the vaccine had like the best antibodies of all. Here, these folks who got fully vaccinated and had a prior infection had 3 to 4-fold more antibodies than everybody else, even the fully vaccinated. They were the best of all. And other studies that I'm not showing you here shows that these vaccine antibodies, at least in the test tube, did a better job of neutralizing the variants, including Delta. We need to I think we need more information on this yet. And then I point out that those that didn't make good antibodies from their infection after they got vaccinated were right up there with the best, making very good antibodies. So I do think we need to maybe stop categorizing the world exclusively in 2 buckets of the vaccinated and the unvaccinated. And I think we probably should be looking more at prior infection as well, and maybe categorizing people more along the lines of presumptive immunity versus no presumptive immunity. So in that presumptive immunity bucket is probably a combination of people who are vaccinated or who have had prior infection. But I think we need to note that both of those groups can lose their immunity over time and get reinfected or get breakthrough infections. And we don't have, I think we need to see more data on how often that happens in the prior infection or not. This is why I think you at least should still consider getting vaccinated if you've had a prior infection. I think the question's a fair one, but I think you need to consider this. Like that study I showed, vaccinated people seem to make about 10-fold more antibodies than those with prior infection. At least in the test tube, antibodies from the vaccine seem to be better at neutralizing the variants than antibodies from prior infection. But as we saw in Israel, those with prior infection seem to be protected a little better for at least that short span of time that they looked at. It was a very short span of time. But we know that immunity fades for both the vaccinated and the prior infected. And I'll point out, just by our own data here in North Dakota, about 1% of North Dakotans that had a prior infection have been reinfected so far. Will that go up? Will that increase over time? And that 1% of reinfected have very similar hospitalization rates, to people with their original infection. And the Israel study and the Kentucky study both kind of confirmed the same thing, that infected people who got at least 1 dose of the vaccine were anywhere from 50 to 57% less likely to get reinfected than those with prior infection alone. I kind of tell those people, if you've had a prior infection and you get at least 1 dose of the vaccine, you're kind of the most golden among us. You have the best protection of sort of all of us out there. So I don't see a downside to getting the vaccine. I see a tremendous upside to get to that sort of the most elite status of the best antibody protection of all. And then you may have, if you want to eat at a restaurant in New York, or you want to fly to Italy, or all the other things where people are going to ask for vaccine status, that's an important piece of it as well. I do think, maybe from the policy side and public health, we need to start looking at how we account for immunity and protection from prior infection. But I'd like to see more data, and those policy shifts do take some time. But I think for your own personal decision making, this is data that might help you with that.